Dr. Yaranov is going to bring us home with a team approach about how to incorporate Barostim into a comprehensive heart failure program.
Thank you. Wow, I feel like we work every day together, and I just learned so much new about Barostim, just like hopefully all of us. Let's see this one. Perfect. All right, so I'm Dmitry Yaranov from Memphis, where Dr. Proctor and I run this advanced heart failure therapy clinic program. It is in this unique tri-state area, not to be confused with New York City tri-state area, although we'd like to call it that way. It's very, very different, and I'd like to show you it to you how so, and hopefully by the end of this presentation you'll learn why we're so passionate about those therapies and why we've grown our program so much. So it's a very large geography, and we do travel through a big portion of this Mid-South, both Dr. Proctor and I, across northern Mississippi, northeast Arkansas, and western Tennessee. Interestingly, now I put a few outreach practices here where Dr. Proctor runs a Barostim program out of Memphis proper, right there in the center. We do have other 3 centers in this area that do implant Barostims in their facilities. One of those is our newest edition of DT LVAD Center, who is also a voracious user of this technology. Okay, so a little bit, a couple more details about us. We're a smaller, mid-size tier transplant center. We have 24 hospital system. We do have everything you do have at Baylor, a little bit less than that, but multidisciplinary team, advanced nurse practitioners, transplant cardiologists, and everything you can think about. We do about 10 to 20 transplants a year, and we do 20 to 50 LVADs a year. So as Dr. Proctor already mentioned, we'll launch the Barostim program in 2022, and just at our center, we've completed close to 80 implants so far. That is not counting the regional implants in our outreach facilities. So what's interesting about all of this, I did come to Memphis back in 2019 from Cleveland Clinic. And I thought that my main contribution to that tri-state area and main excitement about coming down there was the amount of LVADs and transplants I will perform and do in this region. And you can see this is our steady growth numbers. And what is striking here is that actually most of the growth is happening due to heart failure patients and heart failure referrals, and only a fraction of those actually convert into end-stage therapies, and a fraction of those get VADs and transplants. So moving that needle, and I'll show you this publication that came from Dr. Hall last year, is, although our excitement traditionally in training happens on this right side of this graph on the advanced heart failure space, what main contribution of mine in the Mid-South actually happened on the left side of this graph. And it started with guideline-directed medical therapy. And the guideline-directed medical therapy is truly making most of the change in this paradigm. What makes this graph less steep with less downturns in hospitalizations. Our GDMT program, and we published a lot about it, is very aggressive and progressive. Most of the patients, over 90% of those patients, get on quadruple therapy and stay on quadruple therapy in very poor indigent communities. What we've noticed, though, is that as we track all those patients, we've noticed this time lag while we are sitting on quadruple therapy and waiting for those patients to progress to end stages of heart failure so we can offer them VAD and transplant. And a lot of this, what happens is that majority of those patients are in this window or device therapy window, complaining about issues, having heart failure readmissions, and that's the time when we started thinking about what else can we offer. We're so good about GDMT, and we're just sitting and waiting for advanced heart failure therapies. And the hope for this is that you've seen the theme of this through the whole meeting, is that this window of this opportunity can grow and get bigger, and we can get better and better about intervening. Again, to hope that this graph is going to be not as steep with fewer downturns, and we can buy more time for our patients. So this is the graph that I took from Joanne Lindenfeld presentation from now a year and a half ago from THT. And what she's done, she's actually my neighbor from Vanderbilt, who is we have to compete against or work with, right? So what she done is she took all the patients that were enrolled in the BEAT-HF trial, and the BEAT-HF trial that Dr. Val just presented. And what she looked at is she looked at those patients who received Barostim versus those patients who did not receive Barostim, and looked at the utilization of other advanced heart failure therapies that we have in our toolbox. And what she and her co-authors found is that if you were to receive a Barostim, patients in that arm had 74% reduction in receiving additional heart failure interventions, mainly driven by LVAD implants and others. So, and that was the first suggestion of the fact that, again, can we extend this runway? Can we make sure that we delay the need for secondary interventions for those patients? And you've heard us talking about it yesterday on the more advanced side, but this window, is, as it turns out, is a lot wider than we used to think about it. So that actually enticed my research interest in this, and we created this research protocol several years ago, which we just presented at THT this year. Is actually looking beyond KCCQs, looking beyond NT-proBNPs in subjectivity, and talking about the actual numbers that we as advanced heart failure cardiologists love. So we did take those 20 all-comer patients who were referred and considered for baroreflex activation therapy. After we determined that there were candidates for those therapies, we performed a baseline cardiopulmonary exercise testing for those patients. And after patients were maximally titrated in this therapy plus 3 months, we repeated the cardiopulmonary exercise test to see the effects of therapy on the exercise capacity and peak VO2. And you can see lots of dots on this graph. What actually, it translates into that exercise time on the upright cardiopulmonary exercise bike went from 4.9 minutes plus one is 1.6 all the way to 6 minutes. You can see that p-value there 0.03 was very consistent, and the peak VO2 increased from 12.2 to 13.9, and it's very exciting to be talking about peak VO2 in this room, because for general cardiology this may not make too much sense, but this is exactly the area where I live day to day, where my patients are right on that border, and if I can get this peak VO2 from 12.2 all the way to 13.9, that is the time what I'm talking about in terms of extending and delaying the end organ intervention. We did track VCO2 slope and other parameters. Although we've seen some trends, we did not see any statistical difference, so that's why I'll just skip through this information. And I'll show you one more slide, since we're talking about THT here, although with ISHLT, but this is a slide that was presented by Pat McCann, and explain you why I'm showing you this slide, because this nicely supports the protocol that we with EVA have internally. And what Pat did, he looked at his cohort of patients, which is also a very large early cohort of patients, and talk about this anecdote that we've had out there for a while, and mainly is utilization of diuretics in patients undergoing baroreflex activation therapy. So what they found that at 3, 6, and 12 months after baroreflex activation therapy, patients who receive the device, who receive the therapy, are able to come down on the dose of diuretics. So natriuresis is, well-described phenomena in the preclinical studies in baroreflex therapy, but this is the first experience that he was able to show in the clinical practice. And here's why I'm telling you this, because this is how we deal with those patients now that we have a large cohort of patients and get implants every week. This is our titration protocol. So we are very cognizant of guideline-directed medical therapy, how that interplays without titration and diuretic adjustments. So you see that it starts with an index implant, and patients most of the time leave operating room at 1 milliamp. When they come back to see our clinic, and they don't have to see me, nor do they see me, they actually see most of the time our nurse coordinator and nurse practitioners, the titration starts. We titrate in 2-week intervals, and now that is supported by other centers data like PATS, the first thing we'll look at is a diuretic dose at every visit, because a lot of times you will see that you will need to adjust those diuretics as the patients start receiving low doses of therapy. What I mean by this is most of the time you will start going down on the diuretics, not to make sure they don't get over-diuresed. We certainly think about guideline-directed medical therapy and neurohormonal blockade at every visit as well, and I'll show you how, because we are strong believers of GDMT, as I already mentioned to you. As we all know, there's multiple reasons for intolerance of guideline-directed medical therapy, one of them being hypotension. So, and if that is the reason for not optimal doses or a lack of guideline-directed medical therapy in our patients, that we will assess and likely will try to introduce a neurohormonal blockade at every visit. And again, there's more and more data that accumulates. What we are seeing, and we can discuss about it, is that those patients that start titration of baroreflex activation therapy will start showing up in your offices with better and better blood pressure, and you will be able to chronically introduce more guideline-directed medical therapy. And also, if there's other reasons for intolerance for guideline-directed medical therapy, then those will be individually assessed, whether it's access issue, whether it's other non-blood pressure-related issue. That's the time we'll be thinking and reminding ourselves that every touch point with a provider in clinic is a good time to think about it. We do chronically assess those patients, like I showed you, 6-minute walk test for those patients that are outside of the outside of advanced heart failure space, and those patients that are determined to be candidates, we will do serial CP access, just like you would normally do in the regular advanced heart failure practice, to make sure they do not progress in the area where now they need to be listed or VADed. So here's again, this is my biased take on it, or not biased, but in a way, this is what I do in Memphis and how I triage those patients referred into us. For us, cardiopulmonary exercise tool, just like for most of you in this room, is the main triage factor for assessing need for advanced heart failure therapy. And those patients who have peak VO2 less than 12 clearly cross into need of advanced heart failure therapies. It's clear for us if a patient is a transplant candidate, we proceed with hemodynamic assessments. If the resting hemodynamics are abnormal for that patient, we go directly to end organ intervention, whether VAD or transplant. And if those hemodynamics are stable and their cardiac output preserved with normal feeling pressures, and patients do fit the NYHA criteria and other parameters that Dr. Raval discussed, then we would still consider Barostim based on the data I just showed you to see if we can delay the need for that intervention even further while patients are waiting for the intervention. Now, we do push envelope far, as well, and those who are non-transplant candidate, but they still fit the criteria, we will, despite peak VO2, but if they match the NYHA class and they're don't have another end-stage advanced parameters, we'll still consider on a case-by-case basis. the Barostim. But for those whose peak VO2 is more than 12, they have NYHA class 2 and 3 symptoms, or previously 2, but previously 3, those who are not a candidate for CRT, or they were not responders to CRT with persistently low ejection fraction, we would go ahead and implant, and those patients, in my biased opinion, will benefit the most out of this therapy. So this slide, actually, I just got email this morning that is in press and got accepted for publication, and it's creation of Brian Howard, and I texted him last night. He's okay with me showing it today. It's not embargoed, but this is a community approach to put it in perspective for us. Where do we fit therapy like this and others? Pardon me for naming other names that I don't. It was cleared internally, so I hope. But okay, look at this. At the bottom, this is an YHA class, and then up on the other side of the graph is your ejection fraction. All start patients with a guideline-directed medical therapy and a rapid titration, like Dr. Hall presented in her paper. Those patients need to be assessed for ICD and CRT if they were to be a candidate granted the ejection fraction below 35%. Those who have persistent symptoms of NYHA class 4 and ejection fraction less than 25, those patients now will benefit from end organ intervention with LVAD or heart transplant. Not to forget about those whose ejection fraction are higher than that, like HCMs, non-ischemic amyloids. Restrictive patients also be considered for heart transplant only. Most of them will not be candidates for VADs. There's another kid on the block that I'm sure aware of. If your EF is 25 to 45% with class 3 symptoms, sorry about that, will be considered for CCM. And those patients whose ejection fraction is less than 35% fit that criteria will be on that graph. So again, look out for this paper. It's in press, should come out soon. There's a lot more details about how we use it in the community. But the bottom line, just like Dr. Proctor said, it's a team sport. But one thing we've learned rapidly through this team sport is this window of opportunity for those patients becoming wider. Lifelong care of heart failure is our goal, and that's what we do. And we'd like to think about it as in matters of years, rather than therapy, and therapy is delayed, rather than just count the end organ interventions in our practices. Quality of life matters a lot, for some more than quantity, and I'm pointing out those are my patients who actually a lot of times are more dissatisfied with their quality and less concerned about quantity. Individualize, titrate, and initiate GDMT at every opportunity, because that's all, this is a cornerstone of what we do. And I get this question a lot: will use of Barostim decrease my numbers of VADs and transplant on long term? And I hope I was able to show you that no, actually this is a great additive technology into your program that allows for a growth in a very engaged community. Pitfalls to avoid in your programs, it's too late and disease progression is too late, like I showed you in a few slides. Slow, prolonged GDMT titration is not normal and is not good for us or for the patients. And overlooking patient symptoms or burden of them on quality of life is also is not good, and please don't fall into this. So that is it. Thank you so much for your attention, and appreciate you being here.